Okay, everyone. So let me officially welcome you all to another SBR webinar. Today we have an incredible talk. It's called The Methods of Identifying Alliance Ruptures, Pitfalls and Guidelines. Today's presentation is going to be by Dr. Lauren Lipner. She is an assistant professor in the doctoral psychology PsycInfo program at Long Island University, Post Campus in New York, USA. She previously graduated from Adelphi University, where she was trained by Dr. Christopher Muren, Dr. Catherine Eubanks, and the late Dr. Jeremy Safran. Her research focuses broadly on treatment failure, with particular emphasis on alliance ruptures and premature termination. And in addition to her academic pursuits, she maintains a small private practice serving patients in the New York City area. And I've also just found out that she has been an SBR member for 10 years. So this is our 10-year anniversary. Lauren, we are really happy to have you presenting for us today. To our audience, you will be able to speak directly with Lauren after her presentation. In the meantime, if you have any questions or comments, please go ahead and drop them in our chat box, and you can read them out loud at the end of her presentation. So everyone, thank you so much for being here. And Lauren, the floor is yours. Go ahead whenever you're ready.
All right, so I'm gonna hopefully try to share the screen. It worked before, but you never know with these things. Okay, can I get a thumbs up?
Perfect. That's working
Okay.
great.
Awesome. So as was mentioned, I am coming to you live from New York City. That means that it might get noisy and you might hear some sirens, but hopefully it stays quiet for the presentation. And I'm so happy to be here. Very honored that SPR invited me to do this. And I also didn't know I was the grand finale of the year. So hopefully I live up to the expectations. Anyway, thanks all for joining us. As was mentioned, I'll be talking about various methods of identifying alliance ruptures, some things to look out for, and also some helpful hints on moving forward and how to select methodology for this type of research. Okay, so just to give you a sense of what we'll be focusing on today, I know we might have some audience members who are very familiar with the concept of alliance ruptures, some audience members who might be new to this. So we'll start with a little bit of a foundational definitions, then move into discussing some methods, how to select methods for your own research, and we'll end with a case illustration and some future directions. So to start, I'll start by defining the therapeutic alliance, which we really think about as a trans-theoretical and integrative variable. And this work is really based off of Ed Borden's original conceptualization of the alliance, which is composed of three essential components: the purposeful and collaborative agreement on the tasks of therapy, or what is done in a given session, the purposeful and collaborative agreement on the goal of therapy, what are we working toward at the end of treatment, and finally, the affective bond, which I always describe to my students as like the vibes that you have with the patient. We care about the alliance for many, many reasons, but one really good one is that it's one of the most robust predictors of therapeutic outcome. And it's also been conceptualized as a change mechanism in and of itself. But also, on the other hand, weakened alliances have been found to be correlated with premature termination and treatment failure. So what we'll focus on more specifically today within the alliance umbrella is what we refer to as rupture and repair episodes, primarily the rupture side. So based on that Borden definition, you can think of a rupture as a deterioration in the alliance as manifested by when the collaboration on the tasks and goals of treatment fails, or any kind of deterioration in the emotional bond or the vibes between the patient and the therapist feeling off. And I think all of us can think of a time when we're working with a patient where those vibes just seem to feel different or not be going well. That's something we can all connect with. Ruptures have been sort of divided into two main categories, although now we largely think of ruptures as having the capacity to be mixed as well. But for the sake of today's talk, we'll think about withdrawal ruptures or movement away from the other. Also confrontation ruptures, movement against the other. I want to note here that in our initial work, we really thought about ruptures as being patient initiated. So when we first thought about withdrawal, we would think about the patient moving away from the therapist, or in confrontation rupture example, the patient moving toward the therapist. We've since reconceptualized this idea to think that the patient and therapist can equally engage in initiating rupture, such that we're really talking about, in general, one of the actors in the dyad moving either away or against the other. Good news is, when identified by the therapist, it presents the possibility of rupture repair, rupture resolution, and hopefully this could lead to change and better outcomes, as we've seen and previously discussed. So with all that being said, I always like to talk about why did I get interested in the topic of methods for identifying rupture, and it's one of my favorite stories, really, where in my first year of graduate school, I walked into Chris Moran's office. I had an idea for a study. I said, I want to identify ruptures and personality disorders and find how many there are, et cetera, et cetera. And I said, great, so how do I know if a rupture happened? I assumed, given how much research has been done on the topic, that there would be a simple answer to this question. And I did not know that I would be opening Pandora's box by asking a question like, how do I know if a rupture happened? So this was really the inspiration for all this work, which has been going on for 10 years now. And hopefully we're a little bit closer to answering that, though you'll see that there's still some work we have to do. Okay. But in short, in order for us to study ruptures, get a better sense of them, know how to handle them, train students on how to deal with them in their own work, we have to first be able to measure them, and we have to first be able to find them. And the reality is there's no one universally agreed upon method to do this. Researchers all over the world, many of you probably have their own formulas and methods of going about this. In fact, I'm currently working on a study that hopefully will get published sometime soon. Everyone cross your fingers and send good vibes, where I've created a review of various methods for identifying alliance ruptures across the literature. This is a table of only 40 of them. I'm telling you, it's a much larger table than this. I won't bore you with the table. We'll move right along, and I'll give you a summary of the various categories that I've identified. So here we'll talk about task analyses, observer-based methods, direct report methods, and two forms of indirect report methods, criterion-based methods and case-sensitive methods. I'm going to break each of these down. We'll talk about the pros and cons of each approach, and then we'll zoom out and talk about how to pick them. Okay. So the first major category or ways to approach alliance rupture identification is what's referred to as task analyses. Task analyses are multi-step approaches that involve a continuous movement between a process of theory building and empirical analysis. In this approach, we first start by building a model of rupture process from a theory point of view. And this is based on intensive observation of single cases. So we will essentially watch multiple tapes, psychotherapy tapes within the same case to try to understand and create a theoretical model of how rupture unfolds over the case. Later, we will then take that model and test it empirically using group or aggregate level data. So we're constantly moving back and forth between theory building and then testing using quantitative and group level data. If we see that the model doesn't fit well at the group level, we will actually go back and adjust the model and then test it again. A good example of this you might have heard of is the rupture model that is presented in the Safran and Moran 2000 book. You might have heard of it before, but this was all based on an initial task analysis published in JCCP in 1996. So some strengths of this is that it's a mixed methods approach. It involves both qualitative and quantitative efforts, and it includes both single case level and aggregate level analysis. And it's nice in that not only do we receive sort of a definition of rupture, but we're also building a theoretical model on which to continue understanding rupture in the future. And in this way, it really gives us a detailed view of rupture process in general. However, given how labor intensive this method is, the sample sizes included in task analyses are typically quite small, which means we're quite limited in generalizability here. And it also is less focused on the impact of rupture on outcome. It's really more focused on the process of rupture. So we don't get a sense of that link as much as we might see in some other methods. Okay, moving right along to observer-based methods. These are methods that allow third-party observers to identify and track rupture repair markers as they are occurring within a given session. So anyone who has coded sessions before is probably very familiar with these. There are a few different ones out there, and they differ in terms of how they're scored, how granular and level they get, the degree to which they incorporate both the patient and the therapist versus focusing on one or the other. But in general, one of the big things about this is that they're sensitive to even the most minor disturbances in the alliance, and we are able to pick those up. Couple examples here, one major one coming out of Italy, the collaborative interactions scale, and another that I know some people in this Zoom room are quite familiar with, the rupture resolution rating system, or the 3RS. So some strengths here. Of course, when we have a third-party observer doing the identification, there's a certain level of objectivity that gets afforded here. And it also really allows us to have a moment-to-moment breakdown of fluctuations in the alliance or changes in how the alliance is forming. In terms of weaknesses, I think the most major one is that when we're using observer-based methods, we are neglecting the voices of the patient and therapist. We don't get any sense of how they themselves experience the alliance in the moment, and instead are privileging the perspective of that outside observer. And those of you who have coded can also attest, this is quite a labor-intensive process. Before we even get to the coding, there is often an hours and hours and hours long training process, and it takes a while to reach that reliability that we're all seeking. And then you can finally get to the coding, which takes at least the amount of time of the session to complete. So there's a lot of effort that gets put into those. Okay. Next, direct report methods. These are where we will simply approach our patients or therapists and ask, hey, was there a rupture in this last session? So at the end of every session or at the end of a session, we might present a measure to ask them directly if a rupture has occurred. One prominent example of this was published by Chris Martin in 2009, where they would ask at the end of every session, did you experience any tension or problem, any misunderstanding, conflict, or disagreement in your relationship with your patient or therapist, depending on who the responder was? And then on a 1 to 5 Likert scale, if yes, please rate how tense or upset you felt about, the problem during the session. In this way, any time a patient scored this above 1, we would have considered a rupture to have occurred in that particular session from the perspective of the reporter. And just to note, they also ask in this measure to what degree they felt the problem was resolved by the end of the session. So we're getting both a sense of rupture presence, but also whether resolution was able to occur by the time the session ended. This measure has since been translated into several languages and used pretty globally. But there are others out there as well that, again, are mostly focused on directly asking whether a rupture occurred. And I believe there is a new self-report version of the 3RS coming out that would do pretty much have a similar goal here. Okay, so some strength as opposed to the observer-based methods. In this case, we are privileging the experience of the reporter, in this case, the patient or the therapist, over the researcher's operationalization of what a rupture is. So the patient or the reporter, I should say, is the one who's defining for themselves whether a rupture happened and telling us that, as opposed to us imposing our own definition of that onto the reporter. This also gives us some nice guarantee that when a rupture is reported, we know that something of note or something important happened for that person. And so we can feel confident that if we were to go pull that tape, we would probably see something pretty interesting. The tough part of this approach to rupture identification is that it relies on a couple things of our reporter. First, conscious awareness of rupture occurrence, and also memory of the rupture occurrence by the time the session ends. This is probably less a concern when we're thinking about those large confrontation ruptures. But when we're thinking of subtle withdrawal ruptures, this can actually be much harder to detect, and partly because of this reliance on the conscious awareness of it. This is particularly true if the rupture ends up being resolved by the end of the session. Finally, it also relies on the reporter's willingness to tell us about that negative process at the end of the session so directly. And of course, we're thinking about social desirability, and on the therapist side, certainly the fact that they might be doing this in a training setting where they're being evaluated. So there are a lot of things we're kind of hoping will go right in order for this method to make sense. Okay. So moving on to the indirect self-report methods, and I want to break this down before I get into the two types here. When I say indirect, I'm saying that instead of directly asking the patient whether a rupture occurred, instead we're asking them to complete an alliance measure in general. And based on the results of that alliance measure, how they've scored the alliance for that session, we as the researchers are determining whether a rupture was likely to have occurred in that session or not. So we're sort of gleaning whether a rupture happened indirectly based on their alliance scores. So this particular type of the indirect method, which we call criterion-based methods, is sort of the establishment of an a priori designation of a shift in scores by some amount to indicate something important happened, some kind of critical change point. So essentially what we're saying, if the alliance score has dipped by X number of points from session 1 to session 2, we might indicate that there might have a rupture may have occurred. So essentially we're using these to identify sessions in which there's been some kind of quantitative change in alliance scores that may indicate that a rupture happened, or similarly may indicate that a resolution happened if the score creeps back up following that initial drop. The important point to note here is that this quantitative change, however we establish it, is applied to all of the participants in a given sample in the exact same way. So across our sample, we would say if the alliance score dropped by 3 points, there's been a rupture. So we are treating all participants similarly. A well-known example of this would be the Strauss et al. 2006, where they defined a rupture as when the median standard deviation of the CalPES scores across all their patients, when there was a drop by that amount, they coded it as a rupture. In their particular sample, this translated to a drop in the CalPES by 7 points. So notice here that they normed this on the CalPES as opposed to the working alliance inventory, which is a point that I will come back to later. But the idea is they establish some kind of cutoff. It's later applied to all participants in the sample. Okay. So some strengths here is that we know it works in that it's identifying, and it's been shown across many different approaches, not just the Strauss approach. It's been shown to find sessions or ruptures that are predictive of later outcome. It's also relatively easily assessed in that once we determine what the cutoff is, we can pretty seamlessly and quickly apply them to our entire sample. And in that way, it's pretty parsimonious. Everyone gets a similar cutoff score, and it's quite straightforward to use. In terms of weaknesses, we could think about this approach as being pretty nomothetic in nature, in that it doesn't capture as well the individual variability of the reporting parameters of each person. So if we have what we call a flatliner, where their alliance scores differ by no more than 1 point over the entire course of treatment, we will not capture any ruptures for those particular people. And so there is a small subset of participants for whom these probably won't apply as seamlessly. And it's hard for us to combat that by setting more liberal criterion because we could end up flagging non-clinically meaningful events in those patients where we do see a lot of reporting variability. So these, I guess the takeaway being, these formulae don't work as well with capturing individual reporter variability. And finally, and maybe most importantly, this approach will not allow us to find ruptures that were resolved in the same session. So if the rupture happened in minute 5, but was resolved by minute 20, we won't necessarily see those as a result of these formula, because all we're asking them to do is rate the alliance at the end of the session. So we only get a sense of the resolution type alliance, and we might miss anything that might have happened at the within session level. Okay, this is the last one, I promise. So another type of indirect self-report would be the case-sensitive methods, where we will take individualized criteria to identify ruptures for every single participant in a given sample based on their own reporting parameters. So a couple of examples of this: the Stiles 2004, where they flagged a rupture anytime a patient's alliance score was lower than it was predicted to be based on their slope, intercept, curve parameters by at least twice their root mean square error. This is a really fancy way that it was approximately less than 2 standard deviations below the predicted curve. Another example that came out from my team in 2022 was where I essentially constructed what's called control charts for each individual participant. So this is just one patient example here, showing their alliance fluctuations over the course of a 30-session treatment. The solid line going across represents their average alliance score, and the dotted line at the bottom represents essentially approximately 2 standard deviations below the average, similar to the Stiles approach. So in this case, anytime a score dipped below that bottom dotted line, we would refer to or code as a rupture. So in this particular case was session 7 and session 22. So strengths of these approaches, as opposed to what we talked about with the criterion-based methods, is that these are really individualized at the reporter level, in that we're able to take into account the way each person responds to the alliance measure. They're also a bit more statistically complex in that essentially a formula is created to every unique participant, as opposed to the other way around. I think one thing to note here is that because different formulae are being created for each individual participant, we won't necessarily get the same results across participants in the same way we would for the criterion-based methods. They're also a bit more labor intensive. So for those control charts you saw, I would have to go in and code all of those on the back end once they were all created. I could do those in my sleep at this point, so it's not so much of an issue, but they are a bit more labor intensive in that way, in that we have to create the formula for each participant. And for a very large sample, you can imagine there's a lot more work involved. I also note here that it's kind of a weakness that they're more statistically complex, even though I noted it also as the strength. And I put it here just to acknowledge that for people who are less comfortable with statistics, thinking of even clinicians out there who might be interested in tracking their own data with patients, these methods might feel less approachable to those types of people, and so perhaps less used by people outside of researchers hoping to apply these things. Similar to the criterion-based methods, though, this is another approach that we might really miss anything that gets resolved within the session, because we're only getting, again, that alliance score at the very end of the session, hopefully once things have been resolved. So we might not see any within session fluctuation. Okay. So I've just gone through a bunch of ways to do this. They've all been used in the literature. You've probably all seen various examples of these besides the one I've shown. So the question is, so which one should I apply to my own data? If I want to find ruptures, if I want to see them, which ones should I use? So that's bringing me to some guidelines. Hopefully that will help you in making these types of decisions. So I want to review 4 factors that you should consider when you're selecting a method of alliance rupture identification in your own data. So the first, and perhaps unsurprisingly, is the fact that the research question will have implications for what method might make sense for you to use. So if we're interested in getting a sense of how frequently a rupture occurs, more at the between session or between case level, those direct report, where we directly ask patients or therapists whether a rupture occurred, or those indirect methods where we get alliance scores and then try to figure it out later, might make the most sense. As opposed to if we're more interested not in frequency, but actually what did these ruptures look like? The nature of the rupture, how did it unfold over the course of a session? So this would be more at the within session level. For questions like this, we would recommend observer-based methods where we will not miss any of those within session fluctuations that we were talking about, that the indirect methods are probably more weak to. And finally, if we're hoping to build a theory of rupture, what does rupture look like with this particular patient population? What types of ruptures should we look out for in training settings versus in professional settings, whatever? Task analyses might be better fit because the goal of this type of approach is to build theory ultimately. Okay. So another factor to consider is what type of data we have available to us. So if we're using data that's already been collected, of course, whatever we have at our fingertips will determine what we can do. If we have access to videotape, audio tape, or transcripts, this allows us to do things like task analysis or apply an observer-based method such as the 3RS. But if we only have access to sort of post-session assessments, things like alliance scores or rupture questions, we really only are able to work with those direct report or indirect report methods. However, even when we're working with post-session data, we have to really think about what is being collected and from who. So in this case, we really need to think about the reporter. And one thing I want to put out there is that so much of the rupture work that's currently out there in the literature focuses primarily on the patient as the reporter. And we all know that patients and therapists kind of rate the alliance differently, in that therapists tend to rate it lower than patients. We've seen that over time. But much of the formulae that I've reviewed are based on patient data only. So I think the question is kind of out there as to whether we can uniformly apply patient formulae to therapist raters and vice versa. And if we only have access to therapist data, for example, that might limit us in terms of what methods have really been validated by the literature previously. And I mentioned this before, but what measure is being used might also impact things. So while there are a bunch of alliance measures out there, and they're certainly shown to be highly correlated with each other, I have here some examples of the Working Alliance Inventory, the CalPAS, and the Agnew Relationship Measure. They're all related measures, although each of the formulae I mentioned has been really validated on one of these and not necessarily on others. So the Strauss method I mentioned earlier in 2006, that one was based on the CalPES. But the Stiles 2004 was based on the Working Alliance inventory. So if we only have one, I think the question is sort of out there whether we can use formulae sort of and apply them to other measures if that wasn't originally what they were validated for. Okay. Additionally, the amount and frequency of data collection matters. And really the biggest takeaway here is that some of the methods I've talked about need a lot more data than others in order to function in the way we would like them to find those ruptures. So really in particular, those case-sensitive methods need a lot of data because they're constructed based on the reporter's parameters, things like their means and standard deviations, all these things that really aren't reliable if we only have a couple sessions worth of data. Not just amount of data, but frequency of data really matters a bit. So if we're not collecting data at every session, which may just not be feasible for many types of places, we also need to think about conceptually what might a drop in alliance scores mean if the alliance was only measured once a month, right? So if in month 1 it was one score and month 2 was another, and there's been a drop, it's unclear whether that's like a rupture in the way we think about it, or if it's just a sort of regression to the mean kind of thing. And it sort of muddies the waters a little bit if we don't have sequential scores. So one thing to think about potentially is in the absence of regular, and by regular, I mean like almost at the session level data collection, those direct report methods might be the most robust in that they don't rely necessarily on the development of the alliance over time to determine whether ruptures have occurred. Okay. Finally, I think there has to be a question of realistically, what can we pull off? We've already talked about what types of data we will have access to, but in addition to that, many of these approaches, such as the observer-based methods, will require extensive training to execute, and will also require access to coders and a ton of time in order to do that. So that's something we have to consider. And on the other side, some of these are much more statistically complex than others. So that's something to think about in terms of whether that's realistic to execute. All of this in mind, one thing to think about is the reality that our method selection may actually influence the results we get. And to illustrate this, I'd like to share a little bit of a case illustration based on a paper that came out last year now, to sort of demonstrate how these things might change slightly our results. So just to tell you a little bit about the dyad, our patient was a 35-year-old female, white at the time. And our therapist was 24-year-old female, who was operating at the master's level, but in a training site. So her title was an extern at the time. Okay, so a little bit about the diagnoses. So patient based on SCID 1 and 2 was diagnosed with major depression recurrent, but nothing on axis 2. I know that's very old language, but it's an old case. Perhaps more interestingly is the patient's target complaints. This was, we would directly ask the patient what they are hoping to work on in treatment. She had some very interesting things to say. So these are the patient's words directly. Emotional outbursts that are not rational. Most of them happen in romantic relationships, but they've also happened in family and friendships. Secondly, I don't believe in myself. I believe I'm not capable, and any accomplishment I have is a mistake. And finally, I'm afraid if people find out the real me, they won't love me. So the treatment itself was 30 sessions in total on a weekly basis. This was back in 2014 when I first joined SPR, actually. It was from a brief relational therapy approach, which is really an integrative approach informed by much of the research we've talked about today, where there's an explicit emphasis on psychotherapy process and alliance ruptures throughout the supervision and treatment. Okay, so in this particular data collection instance, we used the working alliance inventory, and this was completed by both the patient and the therapist at the end of every session. So we had 30 data points for both reporters. And just to give you a sense of what that looked like, they actually rated the alliance quite similarly. You'll see on average, they were just around 5.1. And not a lot of variability between the two, which is quite interesting. So the first thing I did in looking at the case was just graph the alliance score, and we're focusing on the patient, although I'll come back to the therapist in a little bit. I don't know about you, but right away, my eye was immediately drawn to this like mid-treatment phase because it seemed different from what was happening in the beginning of treatment and at the end of treatment, where things just seemed a little bit more stable. So of course, the question is it a rupture, and a big R rupture that meets all of our criteria? So let's break that down. So we've looked at this case in a few different ways, and one of the things we did was we applied the 3RS or an observer-based method to try to see would third-party observers rate these sessions as a rupture. So the sessions we coded were sessions 12, 13, 14, 15, and 20. Let me go back and show you why we were interested in those particular sessions. So 12 is this high point right before the drop. So I was curious as an example of when alliance was actually, I think it's the highest alliance actually through the entire 30 sessions, what was going on in that session. Session 12, we see the start of a quite precipitous drop. Session 14 is the lowest point of the alliance over the course of treatment. And then session 15, things start to creep back up. And then finally, session 20, we selected as the session where alliance seemed to be back to normal. So that was why we focused on those particular sessions. Okay. So on the left-hand side, the yellow tells us the session number and the working alliance score associated with that session. So session 12, when the alliance was quite high, was all the way to 5.9. And then it starts to decrease from there to 4.2 in the next session, all the way down to 3.67. This is the lowest point of the entire treatment, and later starts to creep back up. On the right-hand side, we have our 3RS scores. Both withdrawal and confrontation, and also how much any ruptures that occurred were resolved by the end of the session. Based on this, we felt that sessions 13 and 14 contained some pretty significant rupture markers, in that you'll see that the overall confrontation score reached a high of 4.5 out of a possible 5. And also, it was coded as having not resolved by the end of the session. 1 is the lowest score you can possibly get, which was achieved in session 13. And session 14 was also a 2, which is quite low, especially in comparison to those other sessions. Interestingly, withdrawal was kind of the inverse of confrontation, in that when confrontation was low, withdrawal tended to be a bit higher. But this didn't seem to have an impact on whether those ruptures were resolved, as we see on that right-hand side. So that was one method. We also had direct report, where we asked the patient at the end of every session, did you experience any tension or problem, any misunderstanding, conflict, or disagreement in your relationship with your therapist? I've replicated our session number and our working alliance scores here, and also our direct report scores, where hopefully it's painfully obvious that session 13 was the only session where the patient noted a rupture to have occurred. This is actually really quite an interesting finding, because they actually rate session 14 as having a worse alliance, but then say there was no rupture. So it's interesting that even within the reporter here, there was some inconsistency within their own data. But I did want to include, these are the patient's own words again, how they described session 13 at the end of the session. She says, "My main problem is how sensitive I am. I don't want to be too sensitive. It is unclear how to fix it because the same conversation keeps happening and we never understand why I act the way I do." So this is a clear, I think, expression of feeling like the treatment isn't working or that the patient isn't experiencing the change they would like to see by this point in the treatment. And this is what's sort of driving the rupture process. But again, just so interesting to note here how the Alliance score was lowest in session 14, but they say no rupture occurred on this other measure. Okay. So that indirect self-report, I applied here the Strauss method. I mentioned previously, this was validated on the CalPES, but I applied it to the Working Alliance inventory. So interesting to think about there. But anyway, using this method, only session 13 was noted as a rupture. Again, session 14 was not. My sense is that rather than thinking of session 13 and 14 as individual ruptures, they were actually coded as part of the same rupture process. So if we were looking at a frequency, there would be one rupture, even though there were two sessions where rupture looked apparent. Okay. So for the Stiles method, where we predicted what their Alliance values should be based on their reporting parameters. Here, only session 14 was coded as rupture. So in this case, 13 was not low enough until we reached session 14. And then that method would have flagged this session as a rupture. I mentioned those control charts earlier. I went ahead and created one for this patient. So we see sessions 13 clearly surpassed that lower dotted line or the 2 standard deviations below the mean. So using this method, only session 13 would be coded because similar to the Strauss method, session 14 is considered a continuation of the same rupture, not a unique rupture. So across all these methods, you see that there are slight variability in which one gets flagged as a rupture and how many get flagged as rupture sessions. Even though, you know, we're using the same data to determine this. And then something I always get asked inevitably when presenting this stuff is whether I actually watched the sessions to confirm whether I thought ruptures actually occurred. And so I did. And what I thought I would do is share a little bit about what these sessions looked like. And these are actually just bits of transcript from a couple of these sessions of interest. So in session 13, patient says, I feel like it's the same thing over and over. I say I'm too sensitive, I'm too sensitive, I'm too sensitive because I am. And then I'm not supposed to say it. And it's just this whole discussion. Well, let's unpack it. Let's talk about why. It just doesn't feel like it gets anywhere. I can keep trying, but it's the same thing that I said in one of my first sessions. I just don't see any light at the end of the tunnel for this. All this just seems like over and over the same stuff, and I don't feel like I get anywhere. So I think we can all agree that there's a clear expression of hopelessness in the treatment, and a confrontation in that the patient is directly expressing to the therapist this idea that what they're doing is not working so far. The next session, session 14, again, the lowest point of the Alliance for the entire case. Patient says, but what kinds of things have we resolved? Isn't there some stuff you're supposed to resolve in therapy? The therapist responds after pausing for a moment. This is where I think we actually differ. I feel like there has been, exploration taking place. I don't know. I guess I can't think of specific resolutions to problems because I also don't know exactly which sort of issues you want to resolve or what you're thinking of when you say patient. Any. I would go with any right now. I just would like to see a recap, because to me, I don't see any and you do. And maybe if the two of us can come together with what I don't and you do, maybe I could feel a little better, you know? So I think here, again, we kind of see some evidence for that idea of a continuation of a similar rupture, where the patient is trying to argue that she's seen no progress, but the therapist is trying to argue she has seen progress, but they're not sure on what page they're sitting on. And clearly we're just not in a place of working together in this moment. I'm going to skip ahead to session 20, where according to the Alliance data, we're back on track, even above average. And let's see what that looks like. So the patient says, I've just felt really, I don't know, I think I said this last week, kind of free. I feel clear. I don't know if that makes sense. Therapist says, sure, if that's your experience. Can you say a little bit more about being clear? Patient says, I think clearly. It's less of, when I feel depressed, I feel like a fog, can't really focus. And I felt really good, clear, and kind of less worried and kind of hopeful. So I think to me, it's very evident that from session 14 to session 20, there's clearly a huge shift in the tone of the session, the level of hopelessness the patient is experiencing, and we certainly seem to be back on track or back on the same page. So all of this to say, I think that even where some of the methods might have differed in which sessions they're flagging, they all did a pretty good job at identifying like actually clinically meaningful or clinically relevant stuff. And certainly none of our methods identified session 20 as being problematic, which lined up with what actually happened in that session. So I guess this leaves us with, oh, where do we go from here? Great question. A couple of future directions I hope we think about moving forward. I think something that's not really discussed enough with this work is how to handle data missingness. And I think the main thing to consider here is when data is missing, we don't know whether it's missing at random or whether it's missing because the patient or therapist were so exasperated by the end of the session that they just said, forget it, I'm not filling this out this week, and threw it in the trash. So I think with data missingness, we cannot assume missing at random, especially when we're interested in rupture process. And it might actually be helpful and best practice to take a look at video or transcripts if we have access to them to confirm whether the missingness might be random or potentially clinically relevant. I mentioned this before too. A lot of the previous efforts have focused tremendously on patient ratings. Even the case study I mentioned was mostly based on the patient ratings. And even if we have the therapist ratings, we often aren't using them or we aren't paying much attention to them. So I think a lot of work needs to be done in taking into account what the therapist has to say. I'm particularly interested in what happens when the therapist and patient have different ideas of what's going on and how do we make sense of that? So there's a sort of newer effort out there on therapist-patient convergence, on whether convergence exists or not. And if not, does that actually indicate more negative process? And finally, there are new approaches for rupture identification developing all the time, constantly. One that I've seen out of Israel with yoga of Kivity is what they call the sawtooth method, where instead of only assessing the alliance at the end of session, they're also assessing alliance at the beginning of session. So they don't only get between session measures, they're also getting within session measures of the alliance. And finally, of course, we have to mention AI and all of this, how AI can be used to help us find these things. Can we actually train AI to code sessions for us? That's been a whole discussion recently. I'm sure we'll continue to be discussing this moving forward. But hopefully there's a couple key takeaways that you'll all leave with today, which is the first, that researchers and clinicians can certainly select formulae or algorithms to identify ruptures that both maximize specificity, but also reduce error based on all sorts of things like how often data was collected, the type of data that was collected, and who the reporter of that data was. And secondly, at least for now, the reality is that we probably need multiple perspectives or formula to best capture the reality that rupture is a really complex and dyadic process at the end of the day. So only focusing on the patient and ignoring the observer or the therapist, we will inevitably lose information. And certainly only focus on alliance scores and not actually watching the tape will also inevitably lose information. So to really capture the entire complexity of the thing, we probably need to employ several approaches. So I'll leave you with that. Thank you so much for your attention. In the wise words of a dear friend of mine, if you liked this presentation, my email's there. If you didn't like this presentation, you should probably lose this email. Anyway, this stuff is currently under review for publication, as I previously mentioned. So if you could all send good vibes to move that along, that would be much appreciated. And I'd like to thank SPR again for inviting me to do this. And I look forward to hearing any questions or thoughts.
Thank you very much, Lauren, for your amazing presentation. It's great work you're doing, very clear. And I personally also love the way you read the case dialogues. It really brings the presence of the mood of that session. So thank you very much, and let's open up the space for any questions, comments that our audience may have. And I think I'm actually going to ask a personal question first. Lauren, I was wondering how you were handling the feedback that the therapist gets from the alliance patient-reported values. If you think that there's any influence or that the therapist might be biased in identifying ruptures based on the patient's response.
So it's a great question. In this particular study, the therapist did not have access to what the patient was saying. So they actually did not see how the patient was rating the alliance or even some of those descriptions that I included. But I think it's an interesting question. And actually, as part of the review that I'm currently working on, I have included an entire section on routine outcome monitoring where the therapist would, in fact, have access to what the patient is saying. And it's kind of one of those, it's a blessing and a curse kind of a thing, because if the patient knows that the therapist is reading it, might we also lose some genuine reporting of any trepidation the patient might have in sharing with the therapist how they're feeling. But at the same time, gosh, it really helps us if we've missed a rupture, but the patient tells us something is off as therapists to go in and address it as soon as we can next time. So anyway, I don't think that question has been explored as much outside of the routine outcome monitoring literature, but I think it's a great question, and it just, I think, probably another future direction worth looking into.
Perfect, thank you. Denise, how are you?
Hello, thank you for your work, first of all, and good vibes. No, I was wondering, I mean, perhaps you don't have the answer because perhaps it has not been studied, but when you have this, we have all of us seen many times this kind of research in which after each session, the patient is asked, how did you feel?
Yeah.
And I imagine if I were the patient, I say, oh, no, don't bother me anymore. You see, so doesn't it interfere? I mean, isn't it a source of rupture? Perhaps not so much in very short therapies, but imagine in 40 sessions, asking 40 times. So I wonder if there is any research on that. This is very important for us because in Uruguay we have psychotherapy is granted for all the population in the national health system, and we are devising a method to assess all the psychotherapy done in the health system in the country, which is it's not me, I'm just helping, but the group who are doing this are doing it very, very carefully. and it's going to be included forcefully for therapists and healthcare services. But then all these kind of questions are very important because you might sort of spoil the party.
Yeah,
Have you
no,
found any research on that?
it's an excellent question. I'd have to see if there are any actual publications on this, but I can tell you, like, from experience in our research program, what we've seen and what I think I'm going to apply moving forward in other places. So this is all coming out of the brief psychotherapy research program. 30 sessions were provided in New York City at low cost to patients. And sort of the trade-off for the psychotherapy being extremely low cost was that they were engaging in some of these research things.
Okay.
Like sessions were recorded and they had all these measures to complete. That being said, I could probably find out in what percentage this happened, but there was always a very decent percentage of participants who would just circle the highest score at the end of every single session and just clearly try to, as quickly as possible, finish the measures so they could go home. This has always been a minority of our particular participants, as in most participants actually seemed to thoughtfully complete the measures. But certainly this did occur. And of course, this makes that data somewhat unusable for us as on the research side. On the other hand, something I've thought about is not doing every session, but perhaps doing once a month or something like this. So it's less intrusive to our reporters, both the patients and our therapists, by the way, who are just totally busy and overworked. I think the hard part is we lose some of that continuity. We don't get to see, at the session level, how this alliance developed over time, but it does mean we might get more meaningful data from more people. So I think it's just a balance, and I think it depends on what is the goal of your data collection in that case.
And I have another question. Perhaps because you have studied this in depth, which at least I haven't, and probably most of us here have not the same depth as you, is how do answers come when you are in a good or bad moment? In the sense, what I mean is, you are during a rupture. So there is a saying, no, anything you say you will be taken against you. So in a period of rupture, you come with this question, isn't it worse for the rupture that I'm feeling awful, and you ask me if I feel awful?
Yeah, and it's interesting. Some patients will respond to that very differently. Some patients love the opportunity to share how awful they feel, and it's actually kind of cathartic. Some patients get really frustrated, and this is where my point about data missingness actually is extremely important, because one thing that may happen is patients say, I'm not filling this out at all. And then when we don't have that data, I don't know if it's because of a rupture or because, I don't know, they were just running late and something happened. I don't know. So I think that's where it kind of gives some more credence to my point that we can use post-session data, but if we never look at the tapes and we never actually get a sense of what was going on in the session, we are inevitably missing really important information.
And I have yet another question. Perhaps I missed it because I had to go out for a few minutes. Are there assessments of rupture by fourth parties? Let's say not the therapist, not the patient, not the observer, but for example, the mother of the child, for example, or the wife or the husband.
Oh, this is one of the reasons I have stayed away from child work myself, but it is certainly out there. I would consider it, though, a sort of unique process in that any rupture a parent or a partner might report will perhaps reflect the alliance between the identified patient and the therapist, but it could also reflect the alliance between the third party and the therapist. And so in essence, you're kind of asking a different question. And so it just depends on how you're asking, but it does exist out there.
Because in child therapy, I mean, the fact of rupture of alliance between therapist and parent is essential because they take the
Yes.
child away.
Right, right. Absolutely true. Thank you.
Chris, go ahead. please.
Oh, you're muted, Chris.
That was a rupture, technological rupture. Yes, I think this follows on from some of the things Denise is saying. That was a hugely impressive and thorough, comprehensive overview. And as such, it feels a bit awful to quibble. But in a way, what I'm always worried about the alliance realm is it seems there's a huge halo, likely to be a huge halo. I think what you're illustrating in some ways is it's when the halo is not simple, probably that in my view, we really are talking about alliance ruptures. When there's a kind of congruence that therapist and client think everything's going swimmingly, probably the self-report measures of where they are will show that everything is going swimmingly, etc. I thought when you did your case analysis, we were seeing something of the fine grain. But as you've said, this is incredibly labor intensive. Incidentally, a short-term therapy of 30 sessions in the UK now is an extremely long-term therapy, which maybe links with one of the things Denise was saying about the realities of publicly delivered therapies. So looking at individual cases in the way you were doing, just don't get enough N. But haven't we got a bigger statistical problem? And I think it's a much more general problem than with alliance measures. It's a problem with all our measures. Increasingly, we're focusing and driving an agenda about what is good therapy from work with what in the UK is now called mild to moderately anxious and depressed clients, i.e. probably most of the clients coming to your service.
Mm-hmm.
We're not dealing with child therapy. I loved it when you said that's why I haven't done child. I didn't either. But I did do group therapy. I did do family therapy. I did a little couple therapy. I hated it. I was very bad at it. The complexities of ruptures when you're doing these kinds of therapies are so complex that with our kind of generalizing nomothetic quantitative dominant model of research at the moment, we're simply not researching these therapies. Half my clinical life, I worked with forensic patients, clients who killed people or raped people. How do you ask them about alliance rupture? You don't. Well, you do. You're pretty wary about it. You don't want to get killed yourself. And I know I'm joking, but I'm also serious because I think what's happened over my lifetime is psychotherapy research has fled from the complexities of day-to-day therapy to concentrate on researchable therapy. And I'm really sorry because it sounds like I'm really fundamentally knocking what you're doing, and it was superb. But I just want you to have a caveat at the end of that paper, which I hope does get accepted, that says, please can we remember, all this research is with a very particular, and I think potentially a very, very small subset of the people who could benefit from psychotherapy. I'll shut up now. Go back to muted.
No, thank you for your point. It's an excellent point. And it's certainly true. The reality of most of the data we're seeing has excluded, I think I just saw on a listserv back and forth, something like 70% of patients end up getting excluded from things like RCTs or these things where we are able to collect all this excellent, amazing data from. And so the question is, who are we really representing? Not only patient-wise, but also therapist-wise, because many therapists are not just working in RCTs types of settings, and are seeing a much larger sense of our clinical population than we see in these papers. I think that is an unfortunate reality of where we're at. I would like to think that hopefully what we have gives us somewhat of a jumping off point to consider. And the reality is, I think we just don't know And I think your point of adding a caveat is extremely astute, and thank you for that.
If anyone has another question or comment, this is the time to do so. You may also use the chat box if you can turn on your microphone.
No, I was wondering also concerning what we discussed in the last webinar or the other when I was in charge about research methods with the non-habitual patients, or with vulnerable populations and this qualitative research, where it's very difficult to do this kind of research, because actually alliance continues to be very important, but there are other instances, for example, class transference and counter-transference, class hate, social class hate. So white and black. So black therapist, white patient, or vice versa. So there's all this issue with the colonizing psychotherapy. So this problem of ruptures, I think is very important to study it, but it should walk towards a much ampler, a much wider scope of perception of ruptures, which do not have to do with the dyad, with the me-you relationship, but with other variables. Now that we have refugees, for example, or I once I was invited to review, I obviously rejected, a paper on Portuguese therapy. Well, Miguel Gonçalves was here. Portuguese therapists doing psychotherapy on Brazilian migrants imprisoned. So, well, you're working for the police and you're my therapist. So you see, I think that the more complex the bond, the relationship, and the kind of therapy is, which is richer, the more difficult, because ruptures are not only do not emerge only from the personal relationship, but from other variables which go beyond or are there before we even have the first meeting.
Yeah.
So
No,
the
absolutely.
real relationship is the real relationship plus.
Absolutely. And I think there's a lot to be done, but I think what you're saying is there's the alliance with the therapist, and then there's the alliance with the institution, and then there's perhaps even the alliance with greater levels of abstraction from there, certainly to consider. And we are not measuring that at all. I mean, to my knowledge, I'm not aware of us paying much attention to this, and you're correct. It certainly will serve to impact the me and you relationship inevitably. And it's sort of hard to disentangle what's what if we're not assessing it. So, yeah.
And the political implications, if you have a therapist who is Jewish,
Sure.
you might be wondering, does he agree on the Gaza invasion?
Yeah, right. Right. Yeah, excellent points.
Lauren, we also have a question in the chat box by Rocio. She's asking, which methods do you recommend to use in private clinical practice to know where to start to measure ruptures to improve our practice?
It's a great question. And I think it sort of depends on a few things, but for me, one of the most simple, straightforward to use that won't require data coding, data analysis, all the rest, is those direct report measures where we just simply ask, hey, did something happen in this session? I think the question from there is whether to ask every session or whether to ask, over the last month, has something occurred, or over the last year, has something occurred? It might change depending on the status. I think someone said in the UK, 30 sessions is very long these days. So I think there can be some room for adjustment. But if terms of minimizing the resources needed in order to get that data, I think direct reports can be a pretty sort of quick and dirty way to get that information and allow you to intervene immediately at the next session if needed. I think there was a question earlier that I didn't get to from Libby. I don't know if she's still here. Anyway, I'll answer it anyway. Can you share your thoughts about indirect case sensitive detection of rupture resolution? For example, how many sessions should we take? And if a client has both repaired and unrepaired ruptures in the process, what will be the pattern of rupture repair? So one thing I want to say about resolution, I didn't say this earlier, I totally could have. Many of these formula that I reviewed today tell us very detailed information about how to identify a rupture. Almost none of them pay as much close attention to how to identify the repair. Many of them will say something like return to previous value, or they may not talk about it at all. So I think there's a lot of room still to talk about how do we know when the thing has been repaired. So that's the second half. How many sessions should we take is a really important question. I think perhaps one of the limitations of the case sensitive options, where again, those are the ones where we need a ton of data to kind of establish the reporting parameters and all these things we need to find the ruptures. There's no clear answer to this, but I would say if we have less than 10 sessions of data, it's going to be very difficult to establish anything with any kind of reliability. So you're looking inevitably at either longer term treatments or treatments where regular data collection is a part of the process in order to be able to apply those methods. So that's, again, one of the limitations of those for sure.
Well, Lauren, I would like to thank you very much for your presentation and to all of our audience for the very moving discussion. I mean, it's very stimulating, what to think about. So thank you everyone. Also, a quick reminder, this presentation has been recorded and you are going to be able to find it in our official webpage from the Society for Psychotherapy Research and on our YouTube channel. I posted the links in the chat box. Also, be sure to look up our social media so you can find out about our future webinars and other events that are organized by the Society, including our a general meeting that's going to take place in Krakow in 2025. So keep an eye out for that. The submission portal is currently open to present both virtual and in-person presentations. And again, just a huge thank you to all of you for your time, for your comments, Lauren, for your wonderful presentation. And also very quickly introduce all of you to Galit and Pedro. They are going to be the next SPR webinar coordinator. So it's great to be able to have you both on the team. And everyone, I'm looking forward to seeing you in February, where we will have our first webinar of 2025. So everyone, thank you very much.
Merry Christmas.
Happy holidays.
Of course.
Merry Christmas.
Thank you, everybody.
Thank
Bye-bye.
you. Ciao.